For an ETV, the burr hole is situated at the coronal suture to optimize the linear trajectory to the foramen Monroe directly at the floor of the anterior third ventricle. Either a flexible or a Hopkins rigid lens endoscope can be used for ETV. Use of the flexible endoscope requires special training, but offers the ability to navigate safely through a narrow foramen Monroe and the pre-mesencephalic cistern. The resolution does not match rigid lens endoscopy, but is very adequate for nearly all cases. Rigid lens endoscopy offers more clarity, but less navigation opportunity. I routinely place a 14 French peel-away sheath to cannulate the ventricle. The sheath provides egress of fluid during endoscopy when irrigation is being used. Upon entering the lateral ventricle, it is important to identify anatomical landmarks. This includes the choroid plexus, septum pellucidum, bellum-striate vein, and foramen of Monroe. With long-standing hydrocephalus, the septum may be nearly absent. The endoscope is carefully navigated through the foramen of Monroe, avoiding injuring the fornix and friable choroid plexus. The key anatomical landmarks of the anterior third ventricle are next identified, which include the mammillary bodies and infundibular recess. I will not perform an ETV without a preoperative sagittal cyst image. It is critical to study the anatomy of the premesencephalic cistern, including the relationship and distances between the mammillary bodies, the basilar apex, and the clivus. Prebasilar distances of less than 3 millimeters are high risk. In general, it is safest to make the perforation immediately posterior to the red disc of the infundibular recess. I prefer to perforate the floor of the third ventricle using the stiffer end of an endovascular Benson glide wire. This glide wire has a rounded tip designed not to injure vascular walls. Electrocautery carries a high risk of vascular injury, is potentially fatal, and is therefore contraindicated. This initial perforation is then expanded using an elliptical mini compression balloon. The endoscope is carefully advanced to the perforation to verify entrance into the premesencephalic prepontine cistern. In some cases, additional balloon augmentation will be needed to get past the premesencephalic arachnoid membrane. Oozing from the stomal edges of the tuberostinarium can be problematic. In most cases, it stops with patience and continuous irrigation. Only rarely has the use of monopolar cautery been necessary.